The yes is not encouraging. Did you have a good time yesterday? I know we kept a bit long. It was up to 6 p.m. We are hoping not to keep you long today. Okay. But it was worth it, wasn't it? The last two presentations were fantastic. The one that dealt with stress and all those ones they were needful. We actually needed to have that one to make up for all the clinical stuff. So that helped. I'm going to play a short video of all the activities that happened yesterday. Before we start, may I call on Dr. Peter Ali to pray for us so that we can start the entire program.
Okay, please shall we be on our feet. Our Heavenly Father, we thank you for today. We thank you for the gift of life and how far you have brought us. We thank you for yesterday, for all the wonderful experiences and all the things that we have learned and all the new people that we got to interact with yesterday. We pray and we commit today's session into thy hands. The Father, you continue to take absolute control. Lead us through the sessions today. May you be with our speakers as they come forth to speak unto us. May you give them utterances. And may you help us to also understand and practice what we are going to do here today. We pray committing our colleagues who are still on their way coming, that Father, you bring them here safely. We thank you and we bless your name. In Jesus' name, amen.
Wow, wow, wow. What a day. So that tells you yesterday was a wonderful day, and it was worth the wait, wasn't it? It was. Next on our agenda is to invite a very versatile man. He has over 20 years experience in delivery quality specialist emergency medical services. He has an impeccable educational background ranging from MA law from University of Ghana, Legon. He has chartered in management and is a consultant. Also an emergency physician. He has Paris Graduate School of Management, has a healthcare management executive masters as well. He has served on numerous boards over the years. And his current role, he is the newly appointed Chief Executive of the National Ambulance Service. Shall we welcome Dr. George Owusu as he takes us through the various remarkable strides that the National Ambulance has made over the years. Dr. Owusu, you are welcome.
Thank you. Good morning. Before I proceed, let me acknowledge some of my seniors around. Professor Nyame, I acknowledge you. Dr. Dennis, you're welcome. Ernest, my regional administrative manager, National Ambulance Duty, can see an executive member of EMSOG, Alice here. That's Joseph Bonny. Is gone out, okay, president of AFAM. I'm very happy to be here, to be with you. I'm part of the EMSOG family. When the president appointed me, within hours, I had a message from EMSOG supporting me in my new role. And I'm also happy to inform you that yesterday I had a hint that I've been confirmed. As the Chief Executive of National Ambulance Service. Thank you. So I will proceed with my presentation. My topic has to do with to reflect, review, and consolidate to build a robust and resilient pre-hospital emergency medical service delivery in Ghana. A look into the future, very long. Yeah, so the presentation outline will be as follows. Reflections, the journey so far, achievements and partnerships, very important. Review the current state of EMS in Ghana. Talk briefly about the operational procedure, our key challenges and lessons learned. Consolidation, that's strengthening the foundation, building for the future, community and public engagement, the call to action, and conclusion. Yeah, so I'm sure you all know how the National Ambulance Service started. It started when we had the May 9th Accra Sports Stadium disaster, where we lost about 127 of our countrywomen. After that unfortunate incident, a lot of committees were set up, and the recommendation was that a service be created to ensure an organized, timely, and professional pre-hospital emergency medical response across the country. And we understand that most of the people who died, they died not as a result of the injuries, but because we lack the necessary timely intervention. So a pilot program or phase was initiated with 7 ambulance stations across 3 regions, Ashanti region, Accra, Greater Accra, and then Eastern, supported by 2 regional dispatch centers located in Kumasi and Accra. We have grown from the initial pilot phase and grown into a nationwide service of about 319 stations and 16 emergency dispatch centers. We started with 57 men drawn from the Ghana National Fire Service, given an initial training in emergency medical response. And this has grown into our medical technicians who number more than 3,000 and are providing service. We have 16, as I said, we have 16 dispatch centers across the 16 regions and 6 strategic locations to have dispatch centers. Response to national emergencies. Over the years, we've played a frontline role in major national emergencies, including the COVID-19 pandemic, road accidents, floods, and other public health crises, demonstrating the services' growing resilience and relevance to national safety and health security. We have a training facility at Nkinkenso, that's in the Ofe North District of the Ashanti region, that sits on a 20-acre land. Our achievements and partnership. Over the years, we've been able to amass 322 ambulances. We'll go into the details as I proceed. Of the 322, we have a fleet availability percentage of around 70. We want to do more. And as I said before, we have 319 ambulance stations. We cover all the 261 districts and the 275 constituencies. On a monthly basis, we see in excess of around 3,000 cases. And since inception of the National Ambulance, we've received over 1 million calls to our dispatch centers. And then we've seen more than 200,000 cases since inception. On a monthly basis, we cover a distance of around 350,000 kilometers per month. As a service, we've been able to, we have legal framework, that is the National Ambulance Service, that gives us the mandate to administer emergency or ambulance service in the country. We've been able to develop an in-house pre-hospital information management system that has all our data, including the dispatches, the calls, and everything. It's set up in such a way that we can integrate it into the national hospital setup and government. Okay, partnership. Over the years, we have strategic partnership with NADMO, Ghana National Fire Service, Ghana Police Service, Armed Forces, Ministry of Health, municipal assemblies, Catholic Relief Services, UCC, KNUST, EMSOG, University of Florida, University of Kansas, University of North Dakota, JICA, Koita, Rwanda Ministry of Health. And if Dr. Bonnie is here, the next few months we'll be training emergency medical technicians from Rwanda. And Dr. Bonnie has been very instrumental in this. Okay. Partnership. So, as you can see, this is the youth president. This picture is here to emphasize the importance of partnership, strategic partnership. As a service, we have financial constraints, but if you are able to enter into strategic partnership, once you have the technical or you have the structure, somebody with the funds will come to your aid for you to be able to do whatever you want to do. Yeah, so in this partnership, we have the men, we have the structures across the country, and YEA they have the money. And with this key partnership, we've been able to train 6,000 community medical respondents across the country. And I'm sure most of you here are either facilitators or administrators with this current program. So I want to stress that EMSOG, we have something unique. We have the expertise. Let us enter into strategic partnership to be able to increase our visibility and to make our impact felt. Okay, another partnership. So when we're giving, or when we signed the MOU with YEA, we needed a training manual. You see, we needed a training manual. We decided to get a training manual. Red Cross, they have a training manual, so we decided to use that. But the publisher drew attention to patency issues. So we then wrote to Ghana Red Cross to give permission to use their training manual. They said, no, it doesn't belong to them. So we have to write to a Canadian Red Cross. It's going to take a very long time. So I was like, we have the men, we have the emergency physicians, we have our EMTs, we have our paramedics, we have our administrators. Why don't we get together, collaborate, and then put up something? And at the end of the day, we're able to come out with this book that suits our terrain. And I want to acknowledge Efia. She did the coordination. I want to inform you that the president is very happy with this book. The president of Ghana is very happy with this book. Okay, so as we review, we want to talk briefly about our current state. So as a service, when it comes to our fleet, we have advanced life support ambulances. We have the basic life support. And then we also have modified motor tricycle ambulances. Service delivery, as I said, we have 16 emergency dispatch centers in all the regions, and then 6 additional ones in strategic areas. We've zoned our ambulances stations to geographical zones, so that even when one of them within the specific zone is out of commission, we can rely on the others to provide service. That means the response time. We run a 24-hour service for minimum of 4 crew in a shift. Human resource. So we started with 57 and drawn from the National Fire Service. But as we speak, we have a total of 3,377 made up of emergency medical technicians, basic and intermediate, advanced EMTs, EMT drivers, paramedics, and non-clinical and administrative staff. We cover all the 275 districts of Ghana. We operate a total of 319 ambulance stations, both rural and urban. And the type of cases that we see: road traffic crashes, domestic and industrial emergencies, mass casualty incidents, disasters, inter-hospital transfers, and we also provide transport when we have to do investigations in our various hospitals. Okay, so this is the emergency response workflow. When we receive an emergency call at our ED center via GOTA, radio, landline, or mobile phone, we initiate a dispatch protocol. And the nearest ambulance is mobilized and then sent to the scene to do initial assessment, triage, and then also provide initial intervention and transport the patient to the appropriate health facility. And then they run to the base to get ready to also respond to another emergency. Okay. National Ambulance Operational Concept. So this is the concept, just like the previous slide. When there's an incident, there's a call placed to EDC center, then an ambulance is dispatched to get to the scene and then take the patient to the health facility. I want to say something here. So when we have to do inter-hospital transfer, the hospital or the clinician in charge legally has a duty of care. You see, if they want to escalate treatment, they have the duty of care to make sure there's continuity of care. So it is the hospital or the clinician, it's your responsibility to ensure that you do and to get to a higher level. It is not the responsibility of the patient. It's very, very important. It's very, very important. So if anything at all, if there's any money or if there's any support, you see, to be given to the national ambulance, it should come from the facility, not from the patient. Because if you want to escalate treatment, you have a duty of care to make sure that your client gets to the next. You have that legal obligation. You see, so we should be mindful about this. We should be very mindful about this. Okay. So when we receive a call from a facility, they want to escalate treatment to a higher level, we also respond and then do that. But I should also emphasize the point that the hospital turnaround time is too long. It's too long. When we bring the patient to the facilities, especially Ghana Health Service facilities, the regional hospitals, the receiving hospitals, it takes too long. Sometimes 2 hours, 3 hours, just to keep, just to receive the patient. And it doesn't help. It doesn't help. It doesn't help. So I think we should be communicating more. We should be communicating more. Yesterday, it was obvious that we are not communicating between the two hospitals that are involved, the transferring hospital and the receiving hospital, and the EMTs. We should elevate the conversation on communication. Very, very important. Okay. So what are the key challenges and lessons learned? As we speak, most of our ambulances are getting to their useful lifespan. They are 6 years, some are 4 years. After 6 years, think about replacing your ambulances, or when they have traveled beyond 130 kilometers, you should be thinking about replacing them. 1,000 kilometers, you should be thinking about replacing them, and we are there. So, so there's a need to replace our ambulance, get new ones. And this is the current ratio. The standard is 1 ambulance to 25,000 population. That is the standard. That for every 1 ambulance, or for every 25,000 of the population, you need 1 ambulance. And if you take our current fleet, that's 322, gives us a ratio of 1:100,000. So if we need to meet the international standard, we need around 1,200 more. 1,200 more. Funding constraints and delayed reimbursements. As I speak, we don't have budget line for the national ambulance. We don't. We're a family, I will tell you why. So initially we were under a special development initiative. So when that ministry was restructured, you see, the funding came from a secretariat at the presidency. But in 2023, the budget wasn't approved. So quickly, we were moved to Ministry of Health to provide funding for us. And per the ministry's arrangement, there's no funding arrangement for for the National Ambulance Service. They don't have the budget for that. You see, so they decided to give us a portion from the National Health Insurance. It's less than 10% of our operational budget. Less than 10% of our operational budget. You see, for fuel, for insurance, for administration, for the tracking system, for spare parts, and then for consumables. So I'm sure you appreciate the precarious situation we are in now. Yeah, but there's hope. There's hope. There's hope. Yes, we've been assured. We've been assured of budget line this year. We've been assured of. Hello, yes. So from here, I'm going straight to Accra to defend our budget at the Parliamentary Subcommittee on Budget. Okay. And from, even when you get allocation from GOG, that's the government of Ghana, it doesn't come as we speak. We can't say everything here, it's okay. Challenges in fleet management. So obviously, when you have challenges with funds, you'll not be able to keep up with your fleet management and all that. Fuel supply, we also had issues, but now it's a bit better. Getting to the end of last year, we were added to what they call security services margin. Yeah, what they give the security services, yeah, from National Petroleum Corporation, yeah. So we get fuel support, even though it's not enough, at least it's helping. The utility vehicles availability. I'm sure you've seen a pickup outside that's been branded National Ambulance. Yes, those are the ones we call utility vehicles. So they assist us in monitoring and all that. Yes, as we speak, we don't have a lot of them. Absence of dedicated towing and support vehicles, a lack of air and water ambulance capabilities, human resource limitations. Ideally, a station should have 16 staff to be able to run the 24-hour service, 4 per crew, yes, and some will be online. But as we speak, you go to a station and there are only 4. There are only 4. Yeah, making it very difficult to run a 24-hour service. Misuse of emergency lines and frequent prank calls. Yes, we do have that. But surprisingly, when I went to the Water Region, they don't have that issue. Water Region, they don't have that issue. You see, they don't have that issue. Lack of legal instrument to effectively operationalize our act. The Act 1041, we have the mandate, you see, but beyond the Act, we need to have the legislative instrument that gives the guidelines, you see, on how to maximize our operation. And poor road infrastructure affecting emergency response. We believe that Ghana's emergency experience proves that local resilience can change global experience in pre-hospital emergency care. So, consolidation, strengthen the foundation where we are now. Good governance. We can't compromise on good governance. So what do we want to do here? We want to implement internal system reforms through data-driven decision-making, strengthen accountability frameworks, and improve monitoring and evaluation. We want to reduce emergency response times. The current emergency response time around 25, we want to bring it down. We want to leverage partnership, very, very important, deepen collaboration with key stakeholders, including Catholic Relief Service, NGOs, development partners, to be able to enhance our operational capacity and innovation. Capacity building and optimizing the workforce, very, very important, very, very important. If we need to drive innovation, we have to empower our people. have to empower our staff. Very, very important. If we want to win as a service, our staff should also win. True of us. Yes. So it's very important that we build a lot of capacity for our staff, and that we need to intensify public education and awareness. We sell emergency services. We need to be on the same page with the public. Are we meeting their expectations? Are we meeting their expectations? We should be engaging more to be able to know whether we are meeting their expectations. Yesterday, an issue came up, whether we just go to pick patients and then transport. We don't do that, or we are not supposed to do that. You see, we are not supposed to do that, yes. So if we are not meeting the expectations, then we need to do more. We need to do more, yes. Maximizing resource utilization. If you don't have a lot, you have to be strategic in the way you apportion your resources. Okay, so building for the future. Building for the future. Our strategic vision, we believe that every Ghanaian is within the reach of quality, technology-driven pre-hospital emergency care, setting a benchmark for Africa. Financial sustainability. We believe that going forward, we should have a dedicated budget line for the national ambulance. We are even saying that pre-hospital care should be integrated into the national health insurance scheme. This is something that we are so much enthused about. When I spoke to the minister, as I said, we cover a distance of 350,000 kilometers per month, all our fleet put together. So if we are even able to get just 10 Ghana cedis, you see, 10 Ghana cedis per kilometer. They say, just 10 Ghana cedis per kilometer. 10 Ghana cedis per kilometer. Imagine what we will get per month. They say, this can support our operations. Can support our operations. So this is something that we want to put across. We've discussed this with the minister, and I think he supports the idea. So we just have to devise a way of actualizing this proposal. If we're able to get 10 Ghana cedis for the basic advanced life support, and then for the advanced, if we get 20, it's okay. We'll be able to get a sustainable source of funding. So this is what we are looking at, looking into the future. And then fleet modernization. As we speak, we have the basic, or what we call the BLS ambulance and the advanced. We are looking at getting more neonatal ambulance. We are looking at getting mobile ICU ambulance. Maybe a few of them, the northern zone, middle zone, and then southern zone. I see, yeah. So that's what we are looking at in the future. And then we want to leverage technology to do things like digital trial, telemedicine. Yesterday we discussed a lot about this. Automatic or computer-assisted dispatch. As we speak, when we have to do dispatch, we do calls. But when we have this system, the system will be able to tell you that this is the most available ambulance that will give you very good response time, GPS, so that you'll be able to avoid traffic. Mm-hmm. The importance of research-driven EMS cannot be overemphasized. We want to do more of local, regional, and then global collaboration. And then we want to also introduce this concept, community paramedic program. Okay. So I'm sure you all know about the free primary health care that the government is introducing. So we want to tap into that. So with the community paramedic program, our EMTs will be given special training, to be able, and the focus is on education within the community. To be able to manage chronic cases at the home level, to be able to give preventive measures at the community level. So we also tap into this idea of community paramedic program, and then align with the government's initiative, and also get something from there. Are you happy about this? Good. Okay. So as I said before, want to develop a phased fleet replacement plan, establish a dedicated fund for the fleet and equipment. We also want to develop or initiate or establish a rapid response motor unit. We say to be able to reduce response time. We say so in congested areas, in traffic areas, cities like Kumasi, Accra, when there's a situation and we have to respond, because we want to reduce response time, the motor unit will first take the lead and then the ambulance will follow. The motor unit will not replace the ambulances. It has to be made clear. The motor unit will not replace the ambulance, but they will take the lead and start with response or intervention before the ambulance will also follow. So this is something that we also have going forward. We want to operationalize our regulatory framework that I've talked about, enhance quality of care and expand coverage from the current 319 to 400 and beyond, to initiate policy dialogue on air and marine EMS, because we have some of our people living in communities that you have to use boats and all those things. So when they have emergencies, we should be able to reach out to them to cover what we all agree, the investor health coverage. Yes. Okay. My time. Okay. So this want to initiate, or we have initiated this community emergency community medical first responder program. We've trained 6,000, and next month we'll be rolling out, or they'll be going to the communities. Public education. School, yesterday the issue of schools and workplace emergency training came up. Yes, we have it here. So as and when we get a hint that somebody has a policy, we will align and then use our expertise and get some funding to do that. Community engagement and ownership. Okay, so at the end of the day, how do we measure our success? So our core KPIs will be response time. You want to do less than 10 minutes, vehicle availability, 90 patient satisfaction, clinical outcomes, EMT training. Train and certify about 500 EMTs annually. Station expansion to increase from 319 to 400. To be ready for emergency preparedness, we want to conduct emergency preparedness drills, exercises in about 50% of our districts. It would be wonderful to do that. Yes. And cover most of the country. Financial sustainability, I've just talked about it. Cost recovery, public awareness, and community partnership, very, very important. And so, as we reflect, review, and consolidate our gains for future readiness, there's a call to action to drive innovation, to research, and to be professional in whatever we do. So we need to strengthen our collaboration and then to build a sustainable service. Let me quote this. We believe that by strengthening our local systems, we illuminate the global path towards equitable, effective, and life-saving emergency care for all. In conclusion, NAS, or the National Ambulance Service, is a vital link between medical emergencies and hospital care. Sustainability depends on partnership, strategic support, and research. We will look forward to a closer collaboration with EMSOG to build a resilient emergency care system in Ghana. Thank you very much.
Thank you very much, Dr. George Owusu, for such an insightful presentation. Thank you, sir. We will defer all questions to the end of the various sessions, and then we can take all. So if you have a question.
Yes, okay.
Okay, so if you have any question, please come to the podium behind the microphone, and then you can ask your question, and we'll move on from there.
Yeah, boss, that's a book.
Wow. 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 Dr. Usu might have to leave along the line. We might not be able to take all the questions. We will limit it to just about 3, and then you can write yours down, and then we will send it across to him. Okay. Just about 3 is okay. Thank you very much. Just about 3. You are not already in the queue, sir. You are not. Very well.
So thank you very much, Dr. Usu. This has been an eye-opener. There are certain things we didn't know. So my thing was, I was happy about the continuity of care, whereby the facility should ensure that the patient gets to the facility. But here is the case that we are seeing something different. So we want to know how you and your team will help enforce that, because it's not the patient's fault to seek for the nest of care from the facility. So how, because we need the education. When you said it, everybody was wowed about the fact that it's the facility's responsibility. But here is the case, the relative, if you don't have money, you are not going, you are there. So how are we going to enforce that the facility makes sure the patient, not the patient and the relative's responsibility? Thank you.
Okay, my question. Please, I'm here on behalf of EMSOG Government Hospital.
Okay.
Yes. Yes, because I have my people here. Please, they say I should ask, as far as the operation of ambulance is concerned, we just want to have it. Secondly, with the funding issues, can we do something like an ambulance levy or something like that? 1% on like the get fund way of, so that we get a dedicated funding for ambulance service. Thank you.
Okay, thank you very much. My first one is a yes or no question before I follow up my comment. As part of your EMT training, do they do clinical rotations? Where do they do the clinical rotations? Do they do at the at the receiving sites? Because I've done my training for 3 years at the receiving site, and I don't remember any EMT coming to a clinical rotation at the receiving site. I say this to say that the whole world is moving towards a One Health policy. And we have to understand, when you made a comment about the duties, you stood there to make a point. And I understand that. We can argue policy to death. But you see, when we work in an austere environment, in a mass casualty, policies get turned upside down. And if you work in the health system in Ghana, every day is a mass casualty. It doesn't matter the situation. So there are many, many times, you have excellent EMTs. I work at Tech Hospital. As for the EMT station there, I have zero problems with them. Excellent service that they provide. We have a wonderful relationship. But what I know is that there are a lot of things that perspective can change. And so I want to recommend that your EMTs do extensive and comprehensive clinical shifts, both at referring centers and receiving centers. Because at the end of the day, what is our vision? We are working in silos. There are the EM physicians, the nurses, the EMTs, the transport staff. But what is our mission? It's about the patient life. At the end of the day, that's everything that we are doing. The end point is saving the life. So we can decide that, oh, this duty is for this person, and this duty is for that person. And when it gets there, they stand on it. Yesterday, okay, I will not mention any names. There were comments made about, today evening, you made a comment about keeping the beds. You see, that keeping the bed, me as the EM physician, I don't want your bed. If I get, the moment the patient gets there, I transport them onto my vent, I'll be happy. I don't want the patient on an ambulance stretcher. It's even bad for my back when I'm trying to do CPR on an ambulance stretcher. I don't even want that. But it happens because there's a bigger system which is frustrating all components. And as long as we are in silos, we will continue to have this problem. So what I understand is that if we break down these silos, you get an experience of what it is on my end from the referring site or on my end as the receiving site. We can work around, this is your duty, this is my duty, this is your duty, to ensure that the outcome that we want, which is the patient life being saved, is actually achieved. Because if you're not creative about it, we will continue to be limited by the systems that govern us. That frustration, it touches everybody's life. And if you don't work around it, and the only way to work around it is to collaborate. And the only way to collaborate effectively is to have similar perspectives. So thank you very much.
Hello. Yes, so we thank you so much for your recommendation. I'm happy our operational men are here, Jude and our facilitators, our health tutors are here. We will add it to our budget or whatever. Okay, on the issue of continuity of care enforcement, I think we need to strengthen our collaboration. We need to strengthen the collaboration between the health facilities, we say, and communicate more. We say, because whatever we do, we say, has legal, ethical, we say, and regulatory implications. So we need to be made aware. We need to be made aware. I say, because you will say that, oh, this and that, but when the law catches up with you, you see, then you know that, oh, so at our facility level, when we need to even place a call, what do? Or when we need to receive a call, we leave that responsibility to a rotation nurse who doesn't have, what do you call it, doesn't have the full grip of whatever is happening. We say, this responsibility should be given to somebody who has an in-depth knowledge of emergency situations and the implications. I say, but just say that there's no bed. You see, somebody rotation, oh, there's no bed. And just like that. But you, as an experienced person, will know the implications. So you know how you manage such situations. Say, yeah, when it comes to the enforcement, it will be very difficult, you see, for you to go to, let's say, Confanochi and tell them they have to do. You see, but by engaging and communicating, they will know their legal obligations. You say, yes. Because when I come to your facility and you accept me as a patient, there is a legal, what do you call it? There's a contract. You say, so you, the facility, when you need to escalate treatment, you have a duty of care to ensure that I get that treatment. So you have to make sure that you facilitate my transport. Say, if anything short of that, you can be found liable. Very, very important. Say, but then what usually comes up, the fact that they also have the budgetary allocation, or they don't charge for that. Say, if they have to escalate treatment, if they have to refer you, they don't bail you. Because if they have that responsibility, then they have a duty to charge you for that. So they claim they also don't have it. So the only thing to do is to judge or to talk to the powers that be, get funding for that. Maybe National Health Insurance for insured clients to pay for pre-hospital care. If it needs to be transported, somebody should pay. It cannot be free. Somebody talked about levy. Talked about levy. In the Finance Act, 1040, there's a sources of funding. It says that in consultation with the Minister of Health and with the approval of the minister responsible for finance, levy will be charged, or a fee will be charged. But we don't want to go there. We don't want to go there. It will be very difficult. To charge the emergency. It's an amorphous area. It's not too clear, so nobody wants to go to the charging bit. Mm-hmm. And and no government will want to impose a levy on the citizenry. People are very hostile when it comes to accepting levies. So you have to be strategic about imposing a levy. So that is why we all welcome the decapitation of the national health insurance, to make more money available for health delivery. So that is where we have to also be strategic and then tap in. So we are also pushing that if we have to give free pre-hospital care, somebody should pay. Like, funds should be made available. Funds should be made available. So we are getting support from the security services margin to support, but it is not enough. It's not enough. We have insurance issues. We have to insure our ambulances. We have administrative costs, headquarters, all the regional administration, the emergency dispatch centers. Training, tracking system. We are talking about tracking systems, spare parts, and consumables, all other things. All involve money. Yeah. So with your ambulance at Nkenken, so we now have to look at it. We'll look at it for you. But you can also engage the district assembly. Now they have a lot of money. Yes, they have a lot of money. And they are supposed to use a portion of their funds or they are supposed to use that funds into health projects. I don't know the specific problem, whether it's an engine problem or an injector problem. They have a lot of money. So let's go to the DC, and a lot of the DCs are helping in this direction. Yes, bringing back most of our ambulances, yes. So I think I've touched on all of them. My good friend, you made a recommendation. Yesterday, the point was made that it seems we only go there to pick patients and transport. We don't want to be seen to be doing that. So we will intensify our car staff training to be able to. We have to meet the expectation of the public. We have to meet your expectation. We have to meet the expectation of the public. We need EMSOG, we need general public for your support. The leaders in emergency, I'm sure together can support each other. As a service, let's realize there's a gradual shift of focus. We say, yes, to security. We are not security. We are medical. We are medical. We are relevant because of our expertise in providing emergency medical service. You see, when it comes to providing security, you see, anybody will go for the police. They will go for the soldiers. They will go for those people. You understand? They come to us because of our expertise in medical emergency. So if there's any place that we need to strengthen, that is what we should focus on. You see, with our in-service training, with our capacity training, that is what we should be doing. We see, so that military bit, you see, it gives morale and all that, but we shouldn't do too much of that. So that will be my take-home message for my great men and women in the service.
Put our hands together for the CEO of National Ambulance, please. Dr. George Owusu. Thank you very much, sir, for your insightful presentation.
Thank you.
We keep receiving solidarity messages across Africa and the world. I'd like to play one before we continue with our presentations for this morning.
Distinguished colleagues, members of the Emergency Medicine Society of Ghana, honored guests, good morning. While I am unable to join you in person, it is my privilege to share a brief message with you today on behalf of the African Federation for Emergency Medicine as we celebrate the second Emergency Medicine Society of Ghana conference. This milestone represents far more than a gathering. It represents Ghana's unwavering commitment to advancing emergency care across our continent. Your growth reflects the urgent need for structured professional emergency care systems throughout Africa, and your progress inspires us all. Ghana has always been a beacon of progress in West Africa, and EMSOG embodies that leadership spirit. your dedication to establishing emergency medicine as a recognized specialty, your efforts to strengthen pre-hospital care, and your commitment to training the next generation of emergency care providers. These are investments in Ghana's future. As we look ahead, AFIN stands ready to support EMSOG's vision. We are committed to strengthening partnerships, facilitating knowledge exchange across African nations, and ensuring that emergency medicine in Ghana continues to grow and thrive. To the conference organizers, the presenters, and every participant at the conference, thank you for your dedication. The work you do has impact and is improving the lives and health of the communities you serve. Let this conference be a catalyst for new ideas, stronger collaborations, and renewed energy. Together, we are building an Africa where every person, regardless of where they live, has access to quality emergency care when they need it most. Congratulations on your second EMSOG conference. May it be impactful, inspiring, and transformative. Thank you.
Dr. Lauren Kane is the Chief Operations Officer at the FM headquarters in Cape Town. May I now invite Dr. Joe Bonny to take over from here.
All right. Good morning, everyone. So the CEO of the National Ambulance Service will have to take his leave. I think a round of applause for him. It's surprising that we managed to keep him in a chair for 2 days. He has equally important appointments to get to. All right. So at this point, we are going to have a presentation on pandemic preparedness. Bako. So we had that all energy when the first one came, and we seem to have been declining. My part of the presentation is to talk to you about the role of emergency care in pandemic preparedness. And it's only going to be a really small part. And then the second part is I will bring the experts from various fields to have a panel discussion on this. See, the pandemic already exposes the fragile nature of our systems. And it brings us to realize that we need to do a little more to keep our systems strong. But I'll go back and do a little definition. What is emergency medicine or emergency care? It's very different for a lot of people. And in this room, emergency care can be 80 beds, 3 beds, 7 beds at KNUST Hospital, or it can be a one-man, one-student station as we have in Cape Coast and other places. There are various ways in which we see emergency care. But as definitions, the most important part is that they present with uncertainties. When you compare emergency departments, inpatients and outpatients, they are undifferentiated patients with no prior rapport. You don't know where they are coming from. You don't know who they are. You don't know what diseases that they are coming with. So we will have to think about it when it comes to diseases. When we look at out-of-hospital care, theirs even becomes a little more compounded. It's an unknown patient with an unknown terrain. And a road you are driving on with a severely injured patient or a severely ill patient, you can see a lot of the presentations. You can see a low SpO2. You might be able to see a fracture. You can see the bleeding. But can you see the virus? So it gets to the point where we're talking about infectious diseases. They then have a bigger burden of who have we picked up that we are moving to the hospital. So the next few slides shows you where we are trying to embed pandemic surveillance. On top of all the hard work people are doing, we are trying to ask them that do more in these spaces. So this is a picture of our hospital, and if our head of department was here, we would have had to clap for him really, because This is no more the state we have in our house. I think we should give ourselves a round of applause. We fixed it for now. Forever. Coming from the head of department of Kumasi South. So. Our next pandemic is coming. It is going to come. There's no way we are going to hide from it. We might be able to stop it in its tracks. And I realized Dr. Dennis Lai was nodding. Some people's job depends on infections being spreading, so there's no spread of diseases, there'll be a problem. But we might be able to stop it in its tracks. We have so many things that are going to increase the level of mortalities. COVID gave us too many millions of cases, with a global death of over 2 million. We have more than 135 million people who are going to be pushed into poverty just because of the cascade of COVID. And we have already set ourselves up for the next pandemic. We are doing too much urbanization. We're moving into areas where typically human beings shouldn't have been. Climate change is there, new and emerging diseases, and so on. So we have already set ourselves on that path. That path brought us to a Marburg outbreak in Ghana. That path has brought Marburg outbreaks in Uganda, Marburg outbreak in DRC recently, and a lot more places where these diseases were not as present. If you look at it, you might say that, oh, there were some cases that happened years ago and there were more deaths then. But we weren't alive then. We should be worried about us now. If we do have another case, where do we go? Over the period of time, we have realized that clinical research is a key to our collective survival. We know this. But at what point do we start this clinical research? What do we mean by active surveillance capacity? We need to develop the ability and skills for individuals within the hospital to identify, report, and perform quality level research so that it can feed into the prevention. The quote says that you see only what you know. So if you can't identify what the various components of the disease are that you piece together to say, this looks like that infectious disease I learned in nursing school, or during my paramedic training, or in medical school, you will not find it. So case definition is really the key. And case definition will only happen within a healthcare setting. I am correcting myself from hospital. Because when you go to a home visit to pick up a patient and they piece it together, you might quickly want to tell the rest of your colleagues to suit up, and then you have become first contact for the patient just because of the presentation. So we've already talked about this. Increased education of case presentation and change of mind will help to alert our clinicians about the cases that we will find. I'll give you two scenarios. In West Africa Ebola, the case identification was late, the marshalling of the resources was late, and we had a big catastrophe in Sierra Leone, in Liberia. Marburg in Ghana, case identification was quick. It was so excessive that if you're not lucky, that day if you came and you sneezed small, we'll test you in that hospital. Early public health action and really reduce the spread of the condition. So we have this golden space here where if clinicians embrace active surveillance, supporting this research, we should be able to find that balance. So what do we do with that admission and discharge book? The details in there. What do we do with the list of presenting complaints? Are we putting them together? Are we analyzing them to find out if we are seeing a trend at some point? This will range within the context in where you work. If you are working in a mobile health systems, if you're working in an ambulance, you're working in a CHIPS compound, the level of work that you will do in identifying will be quite different from what will be happening in a tertiary hospital, who will probably have a little more resources. The diseases will not pick a location. So if you're comfortable that I'm in a nice hospital in Accra, so I don't think this disease will come to me first. I am a quaternary hospital. It will pass through somewhere before, and we'll do national announcements, so we'll protect ourselves. It might not be the case. You might be the first ones to pick up a condition. So I'm taking you back to the emergency department. The challenges of everyday practice, we are already tired. There's a lot of workload. There's inadequate equipment and supplies, and that will not change because that is how a health system is. You'll always be striving to get more. Sometimes the teamwork won't happen well. Somebody has seen a disease, is referring, you don't get a good referral note, you don't know what's wrong with the patient, and now you receive the patient and realize this is a disease that has an infectious component, and we weren't aware. And that then follows the culture of blame. Okay, so because somebody will complain that I am the one that has admitted a patient that has an infectious disease, when you write all the diagnoses and you do query, then you put it at the end so that nobody will say that you admitted the patient on the ward. The settings people work in. We are already, as I said, you have to be educationist, you have to be the advocate, you have to be a researcher, you have to be the clinician, all in one. You the nurse, you the doctor, you have to do all of this. So I already told you, more work, you want us to do surveillance too, but public health, what are you doing? Why isn't public health coming to do the surveillance? Come and sit in the emergency department and do the work. But we realize that you are the one seeing the patients. The case identification, the sample taking skills, handling of the samples and documentation will really have to come from the clinicians at the front end. And this one, we pull our brothers from family medicine in there. They should be ready, that if they see a patient, they capture this and then can report it to public health. The role even extends to monitoring disease patterns in real time. This patient came with this patient came with this. And as much as people don't want to admit, a lot of this transmission of information will happen during handing over. If you saw two patients of the same kind, and you really do not hand over well, and I see another two, I will not be able to create that pattern. Balancing the duty of care versus scientific integrity. Did we take a sample well? Did we hold it well? Did we transport it well? Did we take a good history? So we have some case studies of being able to embed research work into clinical practice. I can only use Confanochi examples. The emergency department at CAT has been able to run the recovery trial embedded into its current activities. So there's some strides to provide that acumen of research, which will definitely border down to surveillance. And so did family medicine also run the anti-cough trial. I already talked about this, that with the capacities will need to be built in order for the ED staff, no matter whether pre-hospital or in-hospital, to be able to support in identification. I will take a few minutes to tell you that we are making it sound like this is what we will do. We have done this before during COVID-19. If you check this, when they called everybody to come and support, emergency medicine was the highest for US specialists who took part in taking care of COVID-19. In Ghana, some of the disciplines ran away, literally, shut down their departments and booted from the hospital. After seeing the first X-ray, radiology was not very comfortable receiving lots more patients without prior notice. Our system in the hospital shows this. So if you take triage as our entry point, at this point, we expect that it should break that chain of getting an infectious disease person into the hospital. But the problem even is much bigger than that. Ensuring that the patients arrive safely through National Ambulance Service, whatever patients you are bringing, providing safe emergency care, and avoiding hospital-wide infections, along with thinking about the mental health and safety of families. You come to work, you pick an infection, and then you are now taking it back home, and staff safety. At this point, I want to keep us all thinking, what did we think we did well during this time? So there were lots of protocol development trainings. The implementation was a little bit tougher than we would have expected. Then a lot of reminders and so on. We concluded by saying that we think we did well. We did see patients, and I will skip through a couple of the slides just to show some of the interventions. Those of you that cannot recognize this, because this is now the space that we now have a construction. When we ran our first simulation, all we had was a screen to be able to hold an infectious disease patient. And this is what led us to develop the protocols that were used in the hospital. So there was some work done for the pandemic preparedness then. There were a lot of training exercises, and this was purely led from the emergency department, where we trained literally the entire hospital on how to manage the cases, looking at the point where we had public health coming to teach mental health during disaster management and first aid. So this is Dr. Danso supporting the training. He's standing at the back. For our implementation, lots of change management and lots of training for what we had to do during that time. And we had to move to passive learning, had to place things everywhere for people to learn as they go. And then some of these processes are still in the hospital, even up to date. But the most important part was being able to have a parallel system. When there is an infection, your hospital needs to continue running for the patients that still require emergency care and are not infected. Your OPD needs to keep running. Your ambulance service needs to keep running, whilst there has to be a clear path for the patients that are infected. So this shows the trend of we still seeing patients versus the patients that we're seeing in the infectious disease unit and the numbers. We already talked about staff care. At this point, I would like to invite my experts panel to join me. We'll move a couple of chairs in front. So we are honored to have a great set to be joining us this morning for the panel discussion. I will start by first introducing Dr. Dennis Lai. So Dr. Dennis Lai trained, and see, we've already established this. He trained in the best medical school in Ghana. He is currently a consultant public health physician, director for surveillance at the Ghana Health Service, and oversees the implementation of public health surveillance. Dr. Lai, please, you can join us here. The next person I will invite is Dr. Ernest Konedu Asiedu. He is also a public health physician specialist. He is the current head of the Medical and Dental Unit Technical Coordinating Directorate at the Ministry of Health. He's really a big man. He is the immediate past of the head of the Quality Management Unit at the Ministry of Health and led the coordination and implementation of the National Health Quality Strategy within the Ministry of Health and across the agencies of Ministry of Health. Dr. Asiedu, please join us. I'm sorry. He also trained in the best medical school in Ghana. And he has a history of being at Asimfusu, where I used to go and enjoy myself whenever I was traveling on the road. See, now I'm being very careful before I introduce the next person because I have a salary that comes from him. When I get it wrong, I'm in trouble. So I'd like to invite Professor John Amwesi. He is the head of the Global Health Department at the School of Public Health and also the head of the Global Health and Infectious Disease Research Group at KCCR, with its sister group as the Global One Health Group at the Bernard North Institute. Dr. Mwesi, please, you're welcome. He also trained in the best medical school in Ghana. And he is still there, supporting that medical school. Last but not the least, we will quickly be joined by Dr. Daniel Osei Kwame. He's had a few challenges. He's here. I think we should give him a big round of applause. He needs no further introduction. The EMSOG president. He had no challenges since he trained in the best medical school in Ghana. So, ladies and gentlemen, our panel for this morning, a big round of applause for them. If you know how difficult it is to get one of these people in a chair, please, photographer, take a picture. It won't happen again to get all these 4 people in one place. Just for the sake of not blinding them with a projector, I'm going to turn it off so that they are free to move around. So our aim here today is to look at the Ghana Health Service, the Ministry of Health, the research arm, and clinicians, and try and find out how we can improve the role of emergency care in pandemic preparedness, especially setting the setting for response and the importance of the EDs being sentinel sites, or being sites where we will pick up. I'll start with you, Dr. Asiedu. What are some of the policies that are needed to formalize the EDs as sentinel sites? What are some of the things that Ministry of Health will have to do to say we are formalizing the emergency departments as sentinel sites?
Okay, thank you very much. Before I answer the question, I think I was listening to some of the questions that came to the National Ambulance Service CEO. And something that was running through my mind, and also per my own experience, was related to cases that are referred from, say, lower facilities to higher facilities. And that may also cause some kind of delay before they get there. And I've just been thinking, what can the ministry do, working closely with implementing agencies, to decentralize some of these emergency services? So the first thing that I think is very important is to have a kind of a specialist training system in terms of how we deploy specialists in the country. Currently, you would notice that a lot of the challenges that we encounter related to no bed syndrome when we get patients referred to the higher levels is also related to the fact that, let's say, the district hospitals may be free. I mean, the beds may be available, but unfortunately, the capacity to manage the patients is a big challenge. So, on top of my head at the moment, I see that that gap needs to be closed. We do know that HEFRA has the minimum requirement for a primary hospital that is supposed to ensure ONG, pediatrics, internal medicine, surgery, and emergency. Unfortunately, I think that part of it is really challenging. And I give this example that I encountered. Usually, our system is not well structured, so most of the time, someone is going to give a call, that you should facilitate something. So I get a call from a friend of mine who is in the US. He trained also in Kumasi. That the mother, they live around Konongo. The mother had been rushed to the hospital. Suddenly around 4 a.m., she got up to go and wee and she collapsed. So when they went to pick her, she was fully conscious. So it means that she had a stroke with the left hemiparesis. So they rushed to Konongo, and then from there, they went to Agogo. Luckily, they were able to do a CT scan because Agogo has it. And they found out that this was an ischemic stroke. But Agogo has also an EMT, an emergency physician. But they needed something, some medication for this patient, and unfortunately, it wasn't available. So when I got the call, I had to make arrangements. I mean, your HOD is also here, so I quickly had to make calls. And then, unfortunately, there is no bed available. And I know that within the first 4 hours, if some treatment is administered, there's likely to be good response. So what the head HOD said, okay, what you should do is that if we want to wait until we get a bed, and this is not a cold case, so you're not going to find a bed, and that if someone else comes, they can say that we are leaving this bed for a certain patient who is going to come, and nobody knows how long. So we brought the patient. But the patient, from 4 a.m. till about 2 a.m. the following day, that ultimately the patient got a bed. Of course, National Ambulance Service, one of the things they hate in their lives is that they have arrived and then, because they will insist, have you been able to make arrangement? Is a bed available? We don't want to go there and wait. Of course, they waited until 2 a.m. before they got the patient. So I was asking myself, if we do have a policy, and I'm saying this from the level of the ministry, in terms of how we deploy our staff, if we had a system where Agogo was capacitated, because there was a bed, and the patient was lying on a bed before they moved, this incident wouldn't have happened. Unfortunately, after some time, the patient couldn't survive, a few days, and then, the patient passed. So from the ministry perspective, I think it's important that we have a document or a policy that will help us structure the way our specialists are also deployed. But I know that it also comes with other things, sometimes outside of the health sector. But like somebody mentioned, the reason why we have trained to be what we are is that we want to save lives. And so we need to work towards ensuring that. The other thing I also want to mention to us is that all of us are potential leaders, or we are already leaders in the role that we play. So King George, not long ago, was an emergency physician, probably also complaining about how the structures up there are not. But today, he is standing here as the CEO, confirmed. And he's also, saying that, we don't have this, we don't have that. So the question I'm asking, who are you crying to? And I can also tell you on authority that the minister sometimes is also crying. So, so all of us here have a responsibility to make things happen. The last thing is that if I see the panel here, we were all in school at the same time. And I look around here, you are all our colleagues. So it means that the power for changing the system is in our hands. It is no longer maybe 20 years ago when we were thinking that there's some power somewhere. The powers are now in our hands. And so together, once we identify a gap, my role sitting in the ministry is to work together to be able to roll something out. Unfortunately, I think we started with the emergency referral policy. And for those of us who are involved, it stalled a little bit. We need to move because some of these things were captured in it in such a way that both routine services can occur at the same time that we run into some kind of pandemic situation. So
thank you very much,
Thank you very
Dr.
much.
Seru. So the policies would need to be linked with people having some level of ownership. That I am going to be the next leader, so let me help build this. Dr. Lai, how will the emergency departments be integrated into be able to provide better surveillance for the national system? We have noticed that a lot of our big emergency services are in the Ministry of Health. And a lot of the 9 surveillance things are in the Ghana Health Service. How do we integrate this, especially into the busy emergency department?
Thank you very much. And thank you for inviting me. I want to say that one of my primary objectives in public health is to see how we integrate public health in clinical practice. So I was smiling throughout your presentation because I think you captured them in ways that I probably haven't thought. So one of the things I'm going to take from you is your presentation. We built our public health surveillance system around public health staff. And I think it's one of the things we need to move away from. Yes, when I graduated as a doctor, and doctors, we all have numbers. So I'm not going to give away how long I've been, but at least my registration number, and recently we had a CPD, and I was looking at the numbers of some of the medical doctors, and it's like a difference of 10,000 between my number and this. So it tells me that we've had quite a number of doctors produced. We cannot have a system that wants to be alert, and yet the people who are at the front are not part of that system. And so for me, a surveillance system without the frontline people, and I don't mean just doctors, because we have various levels of our health system. So we have chips. There are some people, when they get emergency, that's where they will go to. There's a community health nurse there. So that's our frontline person there. If you go to the health centers, we have our physician assistants. There are our frontline staff there. If you come to the hospitals, then we'll have our doctors, and of course at the higher levels as well. So if these people are not at the front, and it's the disease control officer, who will not see the patient? Because when the patient comes in, and again, back to your point, Dr. Pony, your presentation where you speak a lot about the people who are there seeing the patients. If I suspect measles and I do nothing about it, and I wait for the disease control officer to come 3 days later or a week later to come and pick the admissions and discharge book or the OPD register and say, oh, they suspected measles 3 days ago. Let's go find out that patient. That patient is gone into the community already. And I was also very happy about the ambulance service CEO's presentation about duty of care. One of the challenges I had with some colleagues when I was in Konfanoche as the head of the public health unit was that anytime a public health disease was suspected, and Dr. Bonnie also made the point, some people disappear because they think that now it's for somebody else. As a doctor, to the extent that when you have a patient on the ward, you need to take a cerebrospinal fluid sample, you feel it's your responsibility. You need to take blood samples for other things. It's your responsibility. And yet, when a public health priority disease is suspected, the duty of care suddenly is the responsibility of public health people. It becomes a problem. But again, I'm not going to pretend that it's doctors who are shirking their responsibility. It's also because we haven't educated ourselves in ways that allows us to be able to own these responsibilities, to be able to understand that we have a role and that we could be the reason why an outbreak would spread or be contained. I was happy when Dr. Bonnie projected the Marburg outbreak. We had 3 cases, and it's true. It was an alert clinician who thought, no, this is not normal. Let's investigate. And we had our first case of Marburg. It stayed within a family. And even though the case fatality rate was over 60%, there was a lot of action. Professor Moisi was part of the team that was there. Myself, we were aggressive about it because it has come to our notice. And so we need to change the narrative. As I said, we need to move away from it being a core public health function where the people who are doing surveillance are the people who get to see the patient last. Surveillance is information for action. And so the people who are seeing first, and now I'm even thinking about EMTs as well. And again, Dr. Bonnie, you made a point. They get to the house, what is not in their mind, they will not see it. And so they may have gone to the house and they are seeing things, but because it's not there, they won't pick it. So we are not even going to restrict ourselves now to just the people in our health facilities, but I think our EMTs are also going to be key in this. And to make sure that we are doing this well, I am personally going to make sure that now, I think I've told Dr. Endobaini already that I'm joining the association. I want to make sure that we can be able to work together and ensure that we pick these. We don't have to get outbreaks. We can't stop them. We can't stop outbreaks from happening, but we can prevent how much they affect our health system. And the best way to do it is to make sure that everybody is alert. And so the emergencies units have a critical role to play in this. And the emergency units, I'm not just talking about the beautiful ones in Confanochi and the other places, but even the CHIPS compound, where they also have some form of emergency services being delivered there. So thank you very much for the
All
opportunity.
right, thank you very much. And it's really clear that everyone has to be alert. But even when you are alert, Professor Mwesi, what are some of the key challenges in linking that clinical suspicion to a rapid diagnosis or laboratory confirmation? Because it looks like the turnaround time for the diagnostic testing sometimes can be a little of a problem in some cases.
Thank you very much for that, Joe. Again, it's a pleasure to be here. I'll just go straight to the point. The issue of pandemics, and as you've put it, being able to diagnose and this issue of the turnaround time before arriving has always been a challenge. And we saw this especially during COVID because when it started out, there were simply no diagnostics. And it was much later that PCR came on board, and it wasn't very easy to do this for many people at the same time. Eventually got rapid diagnostics, and the rest is history. But I'll backtrack a bit, and I'll say it's important for us to recognize, first of all, as Prophet Bonnie said, I say prophet because he said there will be a next pandemic. So I can christen him Prophet Bonnie. Okay. Well, that being said, I recall prior to COVID, just a few months before, we had a meeting in Geneva and discussed a scenario, global scenario, with a respiratory illness that will shut down all major cities, including the subway of New York, etc. Just 2 days ago, I was looking at a picture that we took after that meeting, a group picture. And I was saying to myself, we must have been very good prophets because it was more spectacular than we had imagined. We did all the simulation of what would happen and what we would do and so on and so forth. And COVID came just a few months later, and it was worse than our wildest possible imagination of any simulation. So I tend to be on the side of the prophet and think that there will be another. What this means is that, pandemics, we like to see them as public health emergencies, but they are also medical emergencies in the same way as they are also research emergencies. The reason why I put it this way is we have a good example from COVID. It was a public health emergency, no doubt. It spread so rapidly all over the world. At the same time, too, it was a medical emergency because people were coming breathless, people were coming with all kinds of conditions that required immediate intervention. And so the emergency physician was king, or queen for that matter, when any patient arrived in a critical condition in a health facility, if there was one present. In the same way, it was also a research emergency because samples needed to be taken, and at the start of the pandemic, it was only in research institutions that the test could be done. For that matter, it was Noguchi and KCCR. And these are research institutions, so it turned out also to be a research emergency. In the same way also, the information that was being collected at the clinical level as well as at the research level was feeding back directly to the public health authorities to understand the direction of the outbreak locally and to inform decisions that needed to be taken. I'm drawing or painting this picture so you see the clear relationships across the board when there's an outbreak. And this is where the issue of being able to diagnose and make quick decisions comes in. We may be lucky if there is an outbreak that there is a known diagnostic, but I prefer to think of a scenario where you have a disease X outbreak. When I say disease X, a disease we've never known before, a disease which we have no name for. And that's what happened with COVID. We were not at the front end of disease X because it happened in China. By the time it got here, it had a name, and we had something to call it, and we could move forward with it. But imagine that there should be an outbreak here in Ghana of something that we don't know. How are we going to go it's not impossible. If it happened in China, it can happen anywhere. How are we going to go about making diagnoses and making clinical decisions? How are we going to make sure that clinicians don't run away? And I remember for Dennis, it was a very painful experience when he was at Conformity. I remember him frantically calling me on the phone in the morning when there was the Ebola, if you remember, and asking KCCR, can you test for Ebola? He said, my physicians are running away. And if you remember, that case turned out to be, and I always use it for very interesting teaching purposes, it turned out to be not only negative, but there were two interesting things. The person checked 2 boxes. 1, Liberian. 2, bleeding. And since it was Ebola, when you hear the words Liberia, bleeding, I'm not going to touch that patient because it was bad news. It sounds funny now, but that's how frustrated Dennis was. Why? Because the capacity to even make a diagnosis was not there. So all I'm trying to point at here is that, first of all, quick thinking physicians, and for that matter, emergency physicians, emergency nurses, and all who work within the emergency space. Quick thinking ambulance EMTs, and those who are working in the ambulance service, etc., is so critical to trying to fast forward the chain of establishing some kind of a diagnosis and then being able to make the right clinical and public health decisions. For the Marburg, it's one of the most beautiful cases of a quick thinking physician. As Dennis said, I was very fortunate. Joe, you were there too, right? We got to interview the physician in person, and it was amazing. If he hadn't thought of what it could be, it could have been a complete disaster. So, well, when it comes to diagnosis and making tests and so on, we are lucky if we have the tests, but more often than not, being able to recognize your role in seeing something that's unusual, making a report, taking the right sample, and following it through, and not thinking that, well, I've done my job, this is not my area, could make the difference between identifying and nipping something in the bud or experiencing a, for that matter.
All right, thank you very much. So if we do not even have the chance to get a sample, there will be no point in looking for a diagnostic lab. And I like this quote, and we attribute it to you. If it can happen in China, it can happen anywhere. Everything is made in China. Dr. Sekwame, what are some of the practical steps in the emergency department that can help us to identify and escalate a suspected disease outbreak? And among all the things that are happening, how will we be able to ensure that we have a parallel system? Do we have enough staff to be able to say people are taking care of possibly infected patients and we are still running the ED as we should run?
All right, thank you so much. I think half of our concerns are probably addressed, especially by the other speakers, because when they begin, especially if public health begins to see the intersection between public health and clinical work, then I think most of our concerns will be addressed. And it's a way for us to cross that bridge and to make sure that there's a seamless operation between public health and clinical setting. That notwithstanding, first and foremost, I think we need, as clinicians, as emergency medical care professionals, we need to leverage our position. And it's been reiterated here already that we are in a unique position, whether we like it or not. I mean, we are the frontline implementers. We see the cases. So if we don't realize that when we're thinking about Marburg, we're thinking about Ebola, we're thinking about measles, I bet you majority of the time it is us who are going to identify these. But whenever we hear public health practitioners talking about these, we begin to think that, oh, somewhere that we are not going to go in the next 10 years or the next month, that's where the outbreak is going to come from. No, it's going to come from one of our emergency centers, and somebody is going to pick it up, and that is how we are going to be able to escalate. We can never escalate without identifying. So for us to be able to escalate some of these diseases of public health concern, we need to first and foremost identify.
And that is where the challenge is. We are used to doing our routine work that we tend to dissociate ourselves from diseases of public health. And there are ways by which we can practically address these concerns. One is by making sure that there is a standardized case of concern, unless probably meningitis. The rest will all be relegated to the background. But if we are able to incorporate the case definitions, and these should be standardized, such that everyone is dealing with the same thing, then it will always prick someone's mind that this person is also falling within this. I know it's going to make triage a bit laborious, but especially when we're beginning to suspect certain conditions, we need to let our triage be quite effective. Now, beyond the triaging system, it's also important to know that work always goes on, whether there is an outbreak, there's a pandemic or not. The normal hand of our work, the pathway doesn't stop. And that is where another challenge also erupts. And fortunately, we've all learned from COVID so much, and we've gained so much experience from what we can do. There are three main things that normally for you to continue doing what you are supposed to do and also caring for whatever outbreak or pandemic, you need to first and foremost think about your staffing, your space, and your logistics. These, you cannot go beyond them. Staffing in terms that you may have to find a way of restaffing both your pandemic pathway as well as your normal pathway. And it's not like you are going to all of a sudden get 100 people to add to your numbers. No, you are not. So you tend to, do what we call reskill a lot of people. So people who are not in the critical roles can be reskilled, and then after reskilling them, you repurpose them. What we mean is that if some people were doing some things to help with the healthcare and they can learn certain other things, you can bring them to join the critical workforce by taking them through certain skills, educational programs, and then you repurpose their work to suit that. With that, you can accrue a number of staff just to add up and beef up to with whatever that you are doing. Your space, you need to make sure that it is, you've had a second look at them, places that needs to be redeployed to bring these pathways, because whatever you do, and one of the things is that whenever there's a pandemic, as much as the pandemic causes a lot of mortality, we also begin seeing a lot of mortality from our normal care pathways. And that is something that COVID also taught us, that by the time we were thinking about the deaths, due to COVID, we were having increasing number of deaths from our normal care pathway. So when you begin to look at your space and seeing where you can reallocate space, and then the logistics, you can reallocate space, and then the logistics. And this is where I would say it goes to all the hospitals here. This is one of the most important clinical issues that we need to address. You see, we need to be able to scale up the usage of these resources. One of the first things that I learned from COVID was that we moved, almost the whole country, we moved from the surge, once there was a surge, we moved straight away from conventional to crisis. And whenever you transition straight away to the crisis, that's what happens. Even gloves became a challenge, because everybody wanted to all of a sudden wear every single thing. Now we need to find a way to scale up our resources such that at every level of surge, this is what we will bring in. So that at the initial moment, we are not bringing every protective equipment out and using it. And once we begin to scale it up, we'll be able to run a parallel kind of care that will effectively address the pandemic as well as address our normal care processes that we are used to.
Right, thank you very much, Dr. Sekwame. It has become clear from a lot of the talk here that somebody is not doing well teaching the people at the front line. Dr. Moise, I'll bring it to you since you are the one closest to the medical school. what are some of the training programs you think can be integrated through medical school? And maybe you would share this point with Dr. Sekwame. And through the training of doctors, house job level, and I will then push it to Dr. Lai to continue about what training programs do they have now, can they push forward? And then if Dr. Siedu will give us the money to be able to fund these training programs. So I'll start with Dr. Moisi.
Thank you very much for that, Joe.
Microphone.
Hello. All right. I think a couple of areas we can look at. I'll start with one which may come as a bit of a surprise, but the area of One Health, I think, is a very critical one. The reason why I raise this is because One Health has been designated as the engine of operationalizing the WHO pandemic agreement, right? Take note, pandemic agreement. So that brings it home. So if the thinking, if at the highest echelons of global health, it has been recognized that to be able to, for the world to be able to come together and agree on how we will behave when there are outbreaks, we need to utilize a One Health approach. Then why don't you make sure that the understanding of this way of thinking flows down all the way into our training institutions? And this shouldn't only be for medical schools or even for the biomedical sciences. It should go much, much lower. And not only at the tertiary level, but also across the different levels of education, the secondary and primary. So first of all, this understanding of the fundamental interconnectedness of humans, animals, and the shared environment, and the risk that we inherently share, where if there is any change in the environment due to A, B, C, or D, the applications for the health of animals and human beings, especially the aspect of zoonotic diseases and how these work. This is very poorly understood. Because at the time I was head of the community health, community medicine department, I managed to smuggle in the topics of One Health into the curriculum. It has come to stay, all right? And so we teach One Health at the now Christian Best Medical School in Ghana. And this was a deliberate decision that was made. It makes a difference to the way people think. The other thing that we need to look at is teaching of research and research methods. We teach community health, but it only scratches the surface when it comes to research methods. And unfortunately, we have embedded research into community health instead of having research across medicine, surgery, pediatrics, whatever you want to call it. I think we should take the research out of community health, spread it across, and give medical students an understanding that research is really key to be able to, in being able to practice properly and be able to contribute significantly, especially when there are outbreaks. I know we have a couple of medical students. Where are you, the medical students? Can you just raise your hands quickly? A bunch of them who are interning with my research group, and we thought to bring them here to have a taste. I was chatting with one of them early this morning, and I said, "How are you finding things?" And he was so, enthralled. He said he didn't know all this existed in medicine. He's a fifth-year medical student, right? He's been exposed to community health, but he didn't know that there was much more to medicine than just the usual. So two things: One Health, and then research methods, and making sure that the research methods are spread across the disciplines, not siloed within community health. Thank you.
All right, thank you very much. Dr. Sekwame.
I think I kind of agree with what Prof is saying, and if I'm to add to it, there are certain things that we are used to doing on regular basis that nobody finds time to teach anybody. Especially, I don't remember back in medical school whether any lecturer or there was any topic like infection prevention control. I mean, I don't remember anybody teaching me back then. And these are things that immediately you come out, you're expected to know, as if, I mean, come to think of it, I really remember during the outbreak of COVID, right? I mean, the people were afraid and everything, but people didn't even know how to put on these PPEs. And it was then that we were teaching people from the scratch, right? And we had to go. I remember Bonnie was part of the team, was an integral part of the team. We needed to go from station to station, practically teaching people the basis of our work, what we are supposed to know from, probably before we even started, practice. So I think finding a way to inculcate infection prevention control in our curriculum may be also a very good start. And additionally, beyond even the schools, whether EMT or whatever, beyond the schools, we need to be able to put up drills and simulations as part of our educative programs. And that will keep us on our toes, because if you do it and within the next year, I don't know when the prophecy is coming, but if the prophecy happens to unfold next 2 years, I bet you within that period of 2 years, a lot of people would have forgotten about most of the things that were taught or were discussed. So if we could come up with drills or simulations targeted at these conditions or these pandemics, I think it will also go a long way to help with getting people with the knowledge and the requisite skills. Thank you.
All right. Thank you very much, Dr. Osei Kwame, on this. So, Dr. Lai, I want to do a little poll before I bring you on board. Maybe I can save you a little trouble. How many of us can honestly say, and this is recent, that they know the case definition for MPOX? If you put up your hand, I will bring you a microphone to say it. Hey! Oh. Cape Coast. Tech Hospital. Confanoche. And you realize that all of you have this. It is in your department. It is on your WhatsApp group. It is at your triage locations. National Ambulance thinks that they are going to escape. We put it on the EMSOG page. You are there. So we had it at some point, but just as we had concluded, a public health for a problem. So, Dr. Lai, how can we try and get the training into our in-service work to get people to recognize that they need to know these as part of what they do?
This is a very scientific poll you've done, and knowing that there are scientists here, people are objective. My only disappointment is that we've had several online CPDs, and I'm going to take the list of doctors here and go and cross-check to see who were in the CPDs and have failed to tell us what the case definition for MPOX is. But yes, I think I agree also with Dr. Sekwame's point and Professor Amuisi's point earlier on our training. And indeed, when I was in Confanoche, one of the things I started, based on, again, the admissions they made, was that you finish medical school, and then the practice, somehow, for some aspects, is completely different from what you are taught in medical school. So doctors don't know about priority diseases under surveillance in Ghana. I was not taught that in medical school. By the way, I collected your slides, so that's why you speak. Yes. So very, well, they are the slides for Ghana, and so yes, they are not mine, personal property. But yes, that's very true. And I like that engagement, Professor Amuisi and I. We go way back, and it's that kind of things we want to see. So we started doing, for the orientation for house officers, I was just presenting on a priority disease under surveillance and what they should do when they suspected it. That was basically it. And we've been continuing with that. What are we supposed to do, or what are we doing currently? As a department, we've had online CPDs, and to my disappointment, nobody in this room was in that CPD, given that nobody remembered the case definition for MPOX. We also do in-person trainings. And indeed, I've targeted teaching hospitals specifically. So we've had IDSR trainings for teaching hospitals, and Dr. Boni has been one of our key facilitators in this endeavor. What I'm taking beyond this meeting, I've spoken about the EMTs, for example. So I'm going to engage your CEO. We need to look at it. It's not just about transporting. And as Dr. Boni rightly said in his presentation, you go to a home, the first person realizes that, look, we could be dealing with something potentially infectious. I am exposed. The other people should not be. And so what are the requisite PPEs? Is it a norm that when you are going to a location, there are full PPEs in there. For example, because it's not always non-infectious medical emergencies you may be dealing with. People may tell you a presentation on the phone, but as I learned as a medical student, we had a patient. It's a digression, but it's a very important thing because sometimes information can mislead you. So I was fortunate, my other colleague wasn't. The child couldn't walk. And any fifth year medical student who's done pediatrics, this is a patient you would want to have in your long case because it's straightforward. But when my colleague went, he met the dad. And this is not in any way an indictment of fathers, but when the father was asked what the presenting complaint was, he said the child has waist pain. Now, a child with waist pain, medical students, what's your differential? But when I went there and the man said the child couldn't walk. So I did very well in that long case. My colleague didn't do well. In fact, unfortunately, he failed. So the point I'm making is that we can get information on the phone, but it will be different from what it is there. So maybe now one of the fundamental things we should have in our ambulances are at least a set of full coveralls and whatever, assuming it's an infectious agent. So we're going to look at that. And then the integration. Professor Amoisi has started, but we need to make sure that it is actually a standard. It's across all medical schools. It's across all residency training programs so that we can be able to have these things there. Unfortunately, in one of our, well, I'll say in Kolebu recently, we had Lassa fever there. And almost 20 of our staff got infected at the emergency department. And this is not to scare you, but that's the truth. We were only lucky the case fatality rate for Lassa is very low. If it had been any of the acute hemorrhagic fevers with higher case fatalities, we'll be singing a different song. And so it's important that we look at this and make sure that it is in there. And we're also going to look at EMT training for public health surveillance. I think it's important for us all. The next pandemic will come. I'm not joining the prophet. I'm just rehashing what the prophet has said. I remember when COVID came in China, I was on a discussion on Joy News, and Professor Ampofo, who used to be at Noguchi then, he said it's not a matter of if, it is a matter of when. The COVID was going to come to Ghana, and it did come to Ghana. So I think that there will be another pandemic. Whether it's going to take another 100 years, like this one took, it's most likely not. Again, in Dr. Bonnie's presentation, he showed us all the risk factors which would hasten the process of us getting a pandemic. So we all need to be prepared. And I think that we all have a role to play in here. He's already reminded us, there are no big people anymore. It's us. The professors are us. The heads of departments are us. The directors are us. And so there's nobody else to look up to. We have to make sure this works, and we would do our best.
All right. Thank you very much, Prophet Lai, for your submission. And it's nice for us to know that job security is very good. We have to prophesy so that those of them in the pandemic space will keep them there. As a member of the One Health Technical Working Group and developing the One Health policy, Dr. Snedu, can you tell us how all of these pieces together at the Ministry of Health? The trainings, the in-service trainings, the new trainings that we are looking at the pre-hospital staff and so on. How will we be able to bring all of this together?
Thank you very much. Okay, so to add my voice to what my colleagues have said, so I think it starts from the training of not only of medical students, but the entire training. I see public health as the health of the public. And if you use the universal health coverage to break it down, there are aspects of promoting health, aspects of preventing, aspects of curing or treating, aspects of rehabilitation, aspects of palliation. And of course, the Ministry of Health's definition and the focus on universal health coverage also splits them, out of this. It teases out emergency care and also mental health support, which is very critical. So if we begin to think about public health as the health of the public, then there would be no distinction between clinical care and public health. I think that is fundamental. So one of the things I would like to propose is that, especially for those of us who have the opportunity to teach, we need to look at it this way. I think when we were in medical school, the assumption was that if you are lazy, then you go and do public health. You don't want to do anything. But you can see Prof here is not lazy. This man here is not lazy. And that's they didn't run away to go and do it. So again, those who were teaching us didn't make it look like. But I'm very happy the way Prof talks about public health now and how we incorporate research, methods and aspects of it into our clinical care makes it look, I would say, more interesting, and not to move away from the thinking that if you didn't want to do anything, then you run away from clinical care and you go into the public health space. So that is it. I want to find out from us, but this is not a poll like, it's a rhetoric. When I was in Confanoche, it was mind, if a person arrives in the hospital with fever and jaundice, such a simple case definition, we'll be thinking about something very, very wild. And one of the differentials that never crossed my mind, and I was always asking my colleagues in child health, nobody ever thought of yellow fever. But this is such a simple case definition, fever and jaundice. It should cross your mind so that possibly it could be. But we'll be thinking about chronic liver disease, severe hemolysis. We'll be thinking about everything. Yes. Intrahepatic, posthepatic, all sorts of things. Anyway, so I think clearly the training, there's a gap between the training, especially in school, and then also what we practice. I'm happy that currently we are bridging that gap with some kind of in-service training and then the opportunity for integrating what we typically do now. Now, when you come into the service, again, normally when we are developing any policy or any document, first there must be a certain problem that will stimulate it. And now that we are all colleagues, any of us has access to bringing something to, for example, the minister's attention through me, and then we know that, okay, this is a gap that we really need to work on. And then we also put together a team from amongst us to be able to look at how we can put this together, and it will guide the way we practice. The last one, I think he had mentioned that some funding aspects of it, or opportunity for us to be able to mobilize some kind of resources. Within the system, when CEO was presenting, one of the things I was thinking about, the IGF that we generate in the hospital is still government money. So, for example, when CEO mentioned, for National Ambulance Service mentioned that when you are moving a patient and we try to shift the problem in terms of funding to the patient and patient family, why can't we use some of the IGF that we have generated in the hospital? And this one, I want our clinic, for example, Confanoche CEO was here. Luckily, he's also my classmate. So I always say that all of us are within the space where we need to solve a problem. Why can't we use some of the IGF that money still belongs to government? And we are saying that government has not given the National Ambulance Service money, for which reason sometimes it ends up becoming very embarrassing that the patient family must fund that one. So I think, again, in terms of mobilization, we are looking at domestic resource mobilization. We need to ensure that some of these funds that we have collected, within the institution are also used. And that way we will not be splitting the thing and saying that these are public health. And typical public health interventions do not generate income. But it's an investment in the health system, which we shouldn't think that we need money to fund and it's expensive. No, it's an investment in the country, in the way that we work. So this is how I would take from here back. But this is the information I also want to carry on to all of us, that public health is the health of the public, and all aspects of it, including clinical care, is found in how we can manage the health of the public. Thank you.
All right, thank you very much, Dr. Asiedu. As we move on, we realize that We are a little out of time, and we might not be able to go through all our questions. So I would probably get into trouble since a lot of people are looking at me, screaming, snack break, snack break. So I will give each presenter about 2 minutes to round up. But as we were talking, we realized that it is really an integrated approach, a very integrated approach. And the point at which we hit epidemics and pandemics, there's one agency in the country who is responsible for disasters. So I'm very happy that we've been joined by the regional director for the NADMO, in the person of Alhaji Ibrahim. And he has walked in when we are asking questions. So, Director, we will have one question for you. What is NADMO's role during epidemics and pandemics?
Okay. Thank you very much. I think I should have changed the time so that I'll be safer. Nonetheless, thank you for the opportunity. NADMO is meant for disaster management. And I think one of the things people have not noted is that our motto is prevention, peace. So now the new regime, we are trying to focus more on prevention. I'm sure that is what all the medical professionals should do. Nonetheless, sometimes the preparation can be less than, and then we get the pandemics. What we try to do is to deploy our men and logistics to support you, because you give the actual care. So for the last one, which is COVID, we had various centers, and we can mount tents. We can also get our personnel, and we have a lot of personnel, you'll be surprised. Currently, we are hitting 825 in the region. Yes, 825. And every district is represented, 43 districts, before you add the regional secretariat. And in the districts, we have also split them into zones, almost like the electoral wards. So we are kind of covered all over. So somebody in the community will easily know a NADMO person. And just like the assemblymen are very powerful in the rural areas, you'll be surprised. NADMO is the first emergency response unit in the rural areas. Whether a house got burnt, a farm had issues, somebody was shot, there was a quarrel, all of that. Yes, it comes to NADMO. I'm sometimes even surprised. The quarrels we have to settle. Yes, including marriages. It's a disaster. I have a meeting on one this Saturday. The woman got her own solution. She has moved out of the place. Now you can't stay alone. Because, yes, family disaster. The woman is gone. The children have also gone where they wanted. Now the man realized that he needs the family. And he's running helter-skelter trying to get support. But me, I happen to know where the woman is. So I'm postponing the meeting so that he'll get to know her value. So I've postponed it about 2 weeks. Because the talk alone doesn't work. So sometimes you have to add some tricks. That is just by the way. But for pandemics, of course, the ambulance service, the medical professionals will be there. But we have the men. Okay? We have operational staff. Yes, as for the men, we have a lot of retired military officers are posted to NADMO. As I'm talking to you, and the women too. We have the men and the women, yes. It's very funny. Women, men. So the men is always present. That is why we use only the men. The women is implied. So pardon me. But I have about 50 military officers. They don't wear uniform anymore. So we normally put them in charge of operations. And some of the way they handle operations is very different from ours. I don't know the medical professionals, but I'll give you just an example. We are going to do a sensitization in the market. We call it Operation OSFIT. Operation Stop the Fire Disasters. There are too many fires and it's causing trouble. 60% of the fires in Ashanti region are from our markets. And nationwide, 80% of the fire outbreaks are from Ashanti region. they cook in the markets. That's what they don't do in Koforidua. They don't do in Sunyani. They don't do in Techima. Ahankwa, ni kuneduani. Before Mujum Hunyana, I've been say or no duani. And they don't care. You see? And when you talk on radio, they won't listen. Even when you are in the market talking to them, more hard to the way and from Hobby, not more dear. I said, about my bedchang and one mattress. I said, yes, but we don't have the mattress and we don't have the rice. So we don't want it to even happen at all. So we are going, and my operations officer is a senior warrant officer, Sambaji, retired. And he was in charge of weapons and strategy at the training schools. So he trained a lot of he did it over 25 years. And it's very interesting. He will look at you, your height, your size, and your demeanor, and he will place you in a team. And he determines the team leaders, and he must write all your names, shout the announcement, and when you go, you come, you have to, if he gave you 5 men for this market, you must return with all the 5 men for him to see and mark the register before he can disband you. Otherwise, you are not closing. So those are some of the things we do for pandemics. They will do the setting, and of course you will do the nurse doctor ratio and all of that. But the people to do the carrying, you do sensitization, right? You advise, but we we like to add enforcement. So we are going to stadium when they are recruiting they are doing the military, exercise, and we meet a taxi driver who thinks NADMO should not be using siren. More coin. Then he takes a cane to help us. This is commercial for you. He didn't know the pickup had 5 passengers. 3 were soldiers. I won't say the rest. I won't say the rest. Cut a long story short, he went home naked. We didn't want any videos and any bad publicity. So they know how to discipline civilians very well. Before they leave the military, they are also trained in that one. So I deploy them in my operations. But they always dress like us, like civilians. So you won't know. So that is mainly what I think we bring to the table. We use our men in the local. Let me add this one. My own place, I live at Diase. So we have landlords association. When the lockdown came, there was no food. And a new area, I don't know if you have observed, a lot of the people who go there first, Shahomami. So a security man, some welder, who can't afford rent, so they go and stay there. So you can imagine, the hunger was so much. I know somebody who ran away and left the family. He has not returned yet. Yes, he left the wife and the children. And there's another disaster. There's a lady on the Okonyempe Tafo. She has about 6 sets of twins. And as at the time, she was under 40. So how many more twins to go? She had 12 kids. The husband ran away. He can't feed her. How does he feed? So we had to gather some money and go and buy some foodstuffs and then find a way of supporting them. So I've kind of been doing the work even before I got into NADMO. But the bottom line is that we are not health professionals. But whatever you tell us, how to carry the patients, setting up tents, all the things, carrying logistics, and getting even volunteers, because we also have NADMO volunteers. We call them disaster volunteer groups. So we can raise more men implied, including women. I'm safe, right? So we can raise manpower to help you in the logistics movement, food distribution, all the things. Basically, that is what NADMO can do to help. Thank you very much.
All right, thank you very much, the Regional Director of NADMO. And it is very important, and it's interesting that the National Ambulance says they have the men. NADMO says they have the men. So it's like, Kwame, do you have the men? All right, so without pushing our time off too much, I would like to give our panelists 2 minutes closing statements around the ideas, the emergency care and pandemic preparedness, and how we can move forward. So maybe I will start first with Dr. Amoisi.
Hello. Thank you very much, Joe, and thank you once again for having me. I'll just reiterate something that I said in my opening remarks, which is that pandemics are public health emergencies, but they are also medical emergencies and they're also research emergencies. What that means is that to be successful in addressing pandemics, this way of thinking needs to be a part of us. And therefore, recognizing the role that you play and not thinking in a siloed manner that I'm only taking care of a really sick person who's rushed into the hospital, but also that my thinking and my actions should consider the broader implications at the public health, at the population level, and also my actions and my thinking should seek to understand better what this means moving forward, and which is where the research comes in. I think this way of thinking will go a long way to improving our ability not only to detect and prevent outbreaks of pandemics, but also to sharpen our response rate and improve the outcomes from all our efforts. So thank you once again for having me.
All right, thank you very much. Dr. Siedu.
Thank you. So mine is to say that for each one of us, the role we need to play is to secure the health of the population. And that way we will not be working in silos, and even goes beyond we in the health sector and bring all the other sectors on board. And when Dr. Amoisi talked about One Health, I even think of One Health broader than the 4 traditional areas that we look at. But One Health as in everything that we are doing, it doesn't matter where you find yourself, it's because we want to secure the health of the population. And it's important for us to think this way and to look and not to separate it, clinical care and public health, so that at any point in time, both the routine services and the emergencies that we encounter can still be handled to secure the population. Thank you.
Thank you very much, Dr. Sekwame.
I remember some years back, there was this argument about who the frontline health professional is. But I believe amongst us, there's no doubt or ambiguity about who we are. And it's something that I think we should always work with. Because if there's any pandemic, it starts with us. Before a number of health professionals get infected and they die, we would have been cleared off. So we need to be vigilant and make sure that we are not doing it only for the public, but we're also doing it for ourselves. At the ED, because of the way we work, by the time we realize that one person is even exposed, within 5 minutes, we will probably have like 15 to 20 of us being exposed because we work, directly close to one another in relation with one another. So please, let's be vigilant. Let's make sure that we are looking out for our brother, and let's communicate. It may be that you've picked up something from Accra, but Kofodia should also be on the lookout. We are not saying that pass a message that there's an outbreak of this. No, just a notice that you are picking up these things, so we should all be on the lookout. May save all of us, and then we may be able to meet here after a pandemic and still having our health intact. Thank you so much.
Thank you very much. And before Dr. Lai comes, we will have only 2 questions, please. So if 2 people want to ask a question, the first 2 at the mic, that's it. There is no gender balance here. All right, Dr. Lai, please, your closing comments.
Thank you very much. So I've put down 5 points. Hopefully I can do that in 2 minutes. The first one is to rehash the point that clinicians and other frontline staff, which Dr. Sekwame has indicated that it's not lost on us who these are, but just for a reminder, it's all of us clinicians, everybody who is the first point of call in any health facility that a patient comes to So whether it's a nurse prescriber, it's a community health officer, we are critical as far as preparing and preventing any pandemic. The second point I need to make is that we need to intensify in-service and pre-service training on especially public health surveillance, but also pandemic preparedness. The third point I want to make is that we need to make sure that the lessons we learned from COVID-19 doesn't fizzle out. Otherwise, we will not be prepared for the next one. We learned on the job, and we got a lot of skills from COVID. It needs to be passed on. And so let's not forget that. The fourth point is about the service I work for. The Ghana Health Service has the mandate to make sure that public health surveillance goes on well in this country. And so the issues we've raised here that border on or have implications from the work we do as a service, we're going to take them up. We'll liaise with all of you to make sure that we strengthen our surveillance system. Last but not the least, I think I made a personal commitment to join your society, but I don't think that I can do this alone. So I'm going to also encourage other people in the public health space to join this society so that we can be able to work together to make sure that we protect our country. Thank you very much.
Thank you very much. We have two questions, so I'll hand the microphone over. It's very delicate to complete my fellowship and to continue to have a job.
Thank you very much. Prof, my question, first question is to you. I understand the concept of research, clinical care. And so if it comes to infectious disease, how do we balance clinical care diagnosis and research? So for instance, I might have come across a patient with a certain presumption which doesn't typically fit known diagnostics. But then I think that we could be looking out for something else. At that point, I have just one patient. So, and obviously, KCCR is a research center, but Konfanoche, for instance, doesn't have the capacity to do a PCR. So that balance, how do we actually can achieve that? My second one goes to, probably Dr. Lai can help me. So again, I have one patient today, one patient tomorrow, the next one the third day. How is our data system able to pick them up together so that we can actually put them together and say that we are having a sequence of presentations that we need to look into? Thank you very much.
All right, thank you very much. So this question is for Dr. Amoisi and Dr. Lai. And just before Dr. Pong asks his one question, our honorable director has to leave now. So thank you very much for your presence. I'm sure he has a disaster to respond to. Thank you very much, sir. Yes, please. Thank you, sir. A round of applause for him, please. The last question.
So mine is not really a question. It might probably answer some people's questions anyway. I want to emphasize the importance of triage in this surveillance, disease surveillance. I want to give this example. It was even pre-COVID, and I will commend one of our triage nurses who observed that about 15 medical students have been treated for malaria. So she brought 2 more to me, and I was supposed to take care of them. Then I was like, she was worried. She didn't know what it was. Like, well, why are 15 medical, for over a period, maybe in a week? So I had to call the dean of the medical school to inform him that this is what is happening. And KCCR got involved. They took the swabs, and it was influenza A, H3 and 2. And that was even before this COVID business. And it didn't come out too much, for obvious reasons. But I realized the importance of the nurses and all the healthcare workers paying attention. And I believe that what helped us was the triage. The Ghana Health Service insists that everybody should have a triage. But what I realized is that when I go around, they only have the proper triage when they are doing the peer review. Is it peer review or whatever they call it? So I believe we have to insist on having a properly organized triage system, and with a constant staff, and they're able to observe the patterns. You understand? So this is a classic example of, and it's not just that one. I remember there was this asthma, thunderstorm asthma. Well, it was a pattern, and they're able to pick it up. But I believe you have to answer Kwekunyami's question, because we have to have better systems rather than using a pattern recognition. So if you can answer us, thank you very much.
All right, thank you very much. We have two questions. I think it was for Dr. Lai and Dr. Onwesi.
No, thank you very much. So the question of research as an integral part of clinical care has always been a bit of a touchy one, particularly when there are emergencies and the thinking is, okay, we have a fire to put out. It is not time for research just yet. But the understanding that we learn by and from doing. So in that process of addressing that emergency or that presentation which is atypical, how can we make sure that we quickly detect something that could be the next pandemic? It all stems from, proper clinical care as well as good science. For example, in recognizing that, well, this person may have an acute, I don't say viral, but at least an acute febrile illness, which is hemorrhagic in nature, would automatically mean, okay, let me make sure I'm properly gowned, or I'm taking extra precautions in seeing this patient. Let me make sure that I'm taking the right kind of samples in the right way as part of my routine clinical care, but also just in case of. During the Marburg outbreak, for example, we had a situation, and this wasn't so broadly discussed, but there was a situation where initially it was thought that there were 2 cases. It turns out it was only 1, and this was just because of how samples were handled, okay? It just shows that if everybody gets it right, first of all, not only will we detect a problem early, but also we would be able to better understand what actually happened, because it threw a lot of confusion into the system as to how could 2 completely disparate people, although from the same area. It was a lot of confusion until it was figured out that, okay, there was a sample contamination issue. So recognizing that we offer clinical care to the best standards, but also every step of the way, taking of the samples, transporting them, keeping them, and so on and so forth, makes a big difference. And we have a role to play. And this is what I'm excited about what he said about this continuous training in IPC, training in several other areas. This is what will give us the quality we need in our clinical care and also reflect in the quality of research. A lot of the research that could bring out knowledge, if you understand the recovery trial and how it worked in the UK and how it is actually working here in Ghana at Konfonochi, it is the routine clinical information which is harvested and then entered into databases. And if this routine clinical information is not of the best quality, you can be sure that there'll be problems with the output of the clinical trial. And so just having this understanding of doing good clinical care to the best quality, good science, reflects on good research. And there really shouldn't be that separation that this is the research and this is the clinical care. There's a place for that, but certainly not when there's an outbreak or when there are emergencies. The 2 should really be arm in arm.
All right, thank you very much, Dr. Lai.
Thank you very much. I'm happy, maybe just a quick digression, especially I'm happy you brought the issue of documentation up. And I know in times past, our handwritings, you know the story around it. The electronic medical record system would have helped as well, but I know there are issues around them. But the key thing is that those of us who attend to patients are in a better position to take information from them than the public health staff. It's very easy for a clinician to ask and get information from a patient that may be a pastor, I dare say, or prophets like Bonnie. So it's very important. Just on Wednesday, we're having the National Measles Verification committee meeting, and most of our measles cases, we don't have information on their vaccination history. But I'm certain that if it's a doctor attending to that, if it's a doctor reporting, the doctor will find a way to get that information. If a doctor asks the patient to go and bring the vaccination card, they are likely to bring it. So again, it affects our response. So just to buttress the point that we need to make sure that we document our information critically or very well. How or what data system do we have to detect what I'll call clusters? And this is what so public health surveillance has two arms. They are the ones that look specifically at diseases, which we call the indicator-based surveillance. So measles or yellow fever, as you mentioned. Somebody comes with fever and jaundice, you suspect yellow fever. And then we have the event-based surveillance, where it's about events. It's anything you think, something is not adding up. So the classic example you gave, a number of medical students having malaria. Does it make sense? At this point, we are seeing so many medical students. Again, as I said, Dr. Bonnie's presentation was very on point because he also gave an example of where even handing over. So if because what's the likelihood that one clinician is going to see or get the information that 15 medical students have come with similar symptoms if no process of passing information on? So sometimes our handing over can be the basis for detecting these. We recognized with COVID-19, one of the lessons we learned from COVID is that event-based surveillance is weak. And so as a country, we've started it. Unfortunately, because of money. So it's not only emergency, National Ambulance Service that doesn't have money. We also don't have money where we sit. And so even though Global Fund came in to support us, they only supported 38 districts nationwide. And even that is with a lot of fight from my department. Event-based surveillance includes what we call facility event-based surveillance. And so some of the pointers that facilities need to be looking at are in those guidelines. Again, as I said, if we can't even use resources in the way that we need at a district level, what can we do with the society, the emergency medicine society, such that such information can be passed on? Because it's important information. And that could be the beginning of an outbreak. Yes, we have a platform. So again, now I'm worried about doing a poll. But who knows about SORMAS? Has anybody heard about SORMAS? Okay, at least what? All right, okay, good. So at least I have two people. But Dr. Ukra, it's not part. But then we have a platform called SORMAS, which, again, has opportunity for this kind of information to be entered. And every kind of information. The beauty of that aspect is that anything that is reported must be documented. So NADMO directors examples, once it comes to their notice, we'll put that in. And we are going to see how we can work with the society to bring those to the fore as well. Thank you.
All right, thank you very much. A big round of applause for our panel. They have been able to really go into this, and it looks like we have left strong action points for Ghana Health Service, Ministry of Health, Medical School, Emergency Medicine Society of Ghana. A lot of them seem to have the men. I think we are worried about the money. Thank you very much for your time. We have just a few announcements. We will have our snack break downstairs in the basement. If you are presenting an oral presentation today, kindly step to the secretariat during the break so that we can have your presentation. From this, we will be having two sessions. AI in health will be in this room, and then our critical care workshop will be in the next room. So please split yourself evenly. AI here, critical care there. Have a wonderful snack break. Thank you very much.